And now the script says, afterwards you will introduce yourself and deliver your talk titled Upscaling MXR in the Netherlands. So that's what I'm going to do now. I never introduce myself, but I will introduce myself. I'm Harry van Goor. I'm based in the Netherlands. And I'm not going to do, like I said, a contest. Who knows where the Netherlands is? Yeah, there are 5 behind. But for the sake of time, this is the Netherlands. And we always think we are second in the world, after the US, obviously, because they are first, they claim. But you see, we have the similar health expenditure, or quite similar as in the US, and we are in the top of Europe, together with Scandinavia. We are trying to reduce that, and also with more introducing digital technology in all fields of healthcare. My talk is about scaling up, so it's completely different from the previous talk, and it's about what did we do from our experience to scale up or to implement VR in our hospital, but also outside the hospital, in the primary care environment. And when you dig into the literature and you look up about implementation and scaling up, you see these types of schemes. And I always think when I see these types of schemes, then it comes to my head, this is a lot of time, a lot of people, a lot of talking, a lot of meetings. And you could say, well, this is a moonshot, but it's more like I want to introduce now the Mars shot. It's more like farther away. So we took a completely different approach. Also because the people in our hospital were asking us 3 things, which is about show us the evidence, the science. Then the other thing is that they asked us to help us, because they were very positive, but they didn't know how to do it. It's more like, how do I implement VR in the hospital or in my department? And obviously the third one is about money. So these questions. And we addressed that in, you could say, in 4 domains. And it's not about that these 4 domains means that you have implemented your VR, not at all. But at least they will contribute to implementation of VR, but also to change the behavior of people that work in the hospital. Because I think, and I think we all agree about that, technology is one, but if you are not changing the way we're working, it will never work, the technology, in healthcare. So I'll start with our service and support. We translate it in Denglish, that's Dutch English.
Oké, dus hier de controller.
Ja.
Dan kunt u een filmpje kiezen wat u het meest aanspreekt.
Schattige dieren. Hallo. En als ik zo doe, nou...
She really communicates with the animals you see. She says hello and how are you doing?
Ik vind dit zo... Ik heb het een beetje doen, maar dat is zo leuk, ja. Ik vind het echt heerlijk. Want ik dacht, jammer dat ik nooit eerder weet heb. Ik ben blij dat ik voor jullie
Nou, fijn.
mag leren. Ja.
So what you see here is one of the aspects of our service and support. And I'll list here what we encompass in this service and support unit. This is all about logistics. So logistics of the hardware and the cleaning and the disinfection, but also because you have technical problems or there are internet problems, Wi-Fi problems, but also the updates that are coming from into the headset. We are sort of an IT liaison to the IT department. Everything is registered and administrated. And then also we give clinical support, meaning that we help nurses and clinicians also to show them for which indications it can be used. And then I think one of the most powerful things of our VR support and service unit is that we are aiming at research. It's also the main person in this that you showed on who you showed on the video is a research nurse. And then obviously everything goes with education, not only the patient, but also educating the staff and other caregivers. So we identified 4 roles of this service and support, which is the virtualist role, which is more or less like also here in Cedars-Sinai, but a little bit different. It's a acute service. So it means that you can scan the QR code and then fill in a short form, and then we come with the headset, and like you, not shown on this video, but most of the time, and that's different from what's happening here, is that patients keep the headset for as long as they need it as a bedside headset during their hospitalization. Also, the research nurse is when there are multiple questions, maybe from different nurses or doctors from the same department. She asked, hey, why are you not doing a pilot study? And then we provide them with formats of outcome measures, etc. And then the other thing is a formal coordination of studies. And most of them are feasibility, pilot studies, and then also, when it's rather getting big, it will be randomized controlled trials. And then some of the departments routinely now use VR in their routine. They have it in their protocol, in their guidelines, and then we use the term maintainer, which means that we go by every 3 months to hear, hey, can we help you? Are there troubles? Is there something that you need from us? So these are basically the 4 roles this service has. Well, these are the typical pictures. You see young people, young patients, elderly patients, but also patients in bed, out of bed, and at the CAS room, so in the outpatient clinic. In 2 years, we used the VR for 25 plus indications. It's now routine at 3 departments: the emergency department, the CAS room, well, it's not really a department, but a facility, and then the pediatric ward and clinic. In those 2 years, we have more than 20 departments connected, and we performed 10 plus scientific studies and published on that. And what really occurs to us is that the step forward in our mind is that it's not only about the traditional things, indications like pain treatment or anxiety or rehabilitation, etc. Also, patients want to use it to escape from the environment. So actually what our dream is and what we want to pursue is that this headset is part of the whole thing of healing environment within the patient room, like shown here, but also that the headset will be something that is part of a patient room when a patient is admitted to the hospital. Then about the money. We started to look at 2 business cases, but also we did a formal health technology assessment. And I don't know how it is in other countries, but more and more our insurance companies are more focused on the health technology assessment than on business cases, because you can cheat around with business cases as much as you want, choose your outcome measures, etc. And they like to have formal, and because they are much more interested in quality of life outcomes. I show you the business case. Well, first I show you what effectiveness outcome, cost effectiveness, what effectiveness outcome do we have to choose. And until, let's say, 2022, we could find only, let's say, 1 proper article about the length of stay. And it shows, actually it's a cost estimation, and it says that it's cost saving so long as it reduces the length of stay by more than 14.6%. Regarding complications, medications, nurse time, satisfaction of the patient, well-being, functioning, there was nothing out there in the literature. We undertook a business case based on nurse time because we think that this is the best key indicator now, or this is the most relevant key indicator now in our daily work, because it's not so much the money, I think, in let's say, Western countries. It's more the nurse shortage that will stop healthcare or progression of healthcare. And as you can see here, in this business case, it's based on VR in post-operative pain, so post-surgical patients. We're very conservative in this, but with this conservative approach, you can see that in year 2, you will save money. And that this will be incremental higher during the years and when you have more patients using XR. So regarding nurse time as an effectiveness outcome, we showed that you have you start, let's say, having back your return of investment within starting in year 2, and then in year 3 it's a benefit. We also, together with some partners, undertook a cost estimation, and this is for wound dressing, so for different health outcomes, but also for different indications. And then it's a more dynamic model where you can choose for your own hospital or ward or whatever, you can choose, will you reduce nurse time, will it reduce pain medication, will it reduce other things, and then this model serves you in terms of will it be red or will it be green like it is in this case. The health technology assessment was on the number of patients or patients discharged from hospital without opioids. And this is as a reason, because the more patients are discharged without using opioids, then you know that on the longer run you will have less patients using opioids at their home, but also there's less development of chronic pain after discharge. So you see it here in this typical HTA decision tree. We had to correct for epidural or no epidural, and because that's a mainstay, at least in our country, that most of the operations, at least at the complex, the bigger operations, are under epidural plus obviously general anesthesia. And this is very interesting because you're probably maybe not familiar with HTA, but this is expressed in ICER, so the incremental cost effectiveness ratio. And like you show here is, the ICER here is 10,000 euros. And 10,000 euros, and that's based on an effect of only 3.7% reduction of patients discharged without opioids. And this is considered cost effective. To give you an impression, when it's 20,000 per QALY, then you start thinking, hey, is this worthwhile introducing this technology? And maybe to graphically support this, this number of 10,000 is in the green area, and here you can also play, you can model. So suppose you want to have, let's say, lower cost of VR, higher cost of VR, and maybe a bigger reduction of patients leaving the hospital with opioids. You can play with it and see if you are in the blue area where you save money, or you're in the red area where you have to think about, okay, are we introducing this? Then the fourth thing. And the fourth thing is the topic of VR in connected care, in a connected care system. And this was based on more and more requests, and that started already in the COVID time, for patients using VR at home. And there were more and more patients asking us, can we take the VR goggles at home for rehabilitation after surgery, or also patients that had to prepare for surgery. In the Netherlands, rehabilitation, I don't think it's in the US or in Canada that big, but it's starting very big in the US and also other Western European countries, where they prepare for 4 weeks for surgery, for elective surgery, to come in a better condition, etc. 5 minutes left? Okay. So both from hospital to home to hospital, we thought, okay, we have to create a connected care model with VR. And then we thought, okay, but now you are able to put VR in the center as a self-administered treatment tool for patients to exercise or to have other treatments, mental or cognitive treatment at home. And then the advantages in VR is that you have different therapies. I dare maybe a little bit to say you have different disciplines in one tool, in one solution. And then not only the headset, but also maybe the connected wearable data or other data, you can have continuous data for monitoring, which actually our physiotherapists in our country, it's a problem because physiotherapists, well, they give exercises at home. They don't have a clue that patients are exercising. But now you know that the patients are exercising because the data comes from the VR headset. And it's not about big brother watching you, it's more about, okay, now we have another conversation when the patient comes to the office. It's more like, okay, more targeted conversation. Hey, I see that you didn't have time to practice or you didn't practice, what was wrong with it? Exactly. And then VR is becoming a reality for teleconsulting. Now we are able, with a tablet, to see what the patient is doing in the virtual environment. And within 1 or 2 years, we also are able to coach in the virtual reality space. So from a distance, the patient. And then obviously, we can automate and integrate care, and you can level care to other experts and put them together on one data platform. I'm not going to much in detail. We also did a modeling for prehabilitation, rehabilitation at home. And the reason we were not able to do an official business case, but a modeling is because there are no data, not enough data out there for this particular indication. But as you can see here, that if you have a patient for prehabilitation 30 days, and you have you have 1,250 patients, you have to, let's say, pay 321 euros. So it means that you somehow have to save 321 euros to break even. But the next step was that we were thinking, hey, are people working in a hospital, are they interested or do they have the right DNA to do this virtual care with VR? I doubt, because they work in hospitals, they want to see patients, they want to touch patients. So maybe it's a different DNA for virtual care. And we collaborated with a medical service center who is used to do virtual care, but then more as a home care. They do 20,000 monitoring, patients monitoring from a distance, elderly patients, etc. So we collaborated with them, and we projected together that we have this virtual connected level care where the primary care is done by nurses from a distance, and then they can upgrade or level the care into specialists. And the specialist is also the physiotherapist. So we turn it a little bit around. The patient's direct connection is the nurse or even another person, and then the one who's most expensive is at the site in the outer circle. And this is, we did a business case on that, and that means that we have a different system. The hospitals in the Netherlands, the insurance company is not saying, okay, we pay you. So what actually the idea is that the hospitals have to invest first, and then have the idea, okay, we can have money back, because we receive from every, that's a DRG system, we get a lump sum for a particular indication, etc. And it means that when the hospital pays for prehabilitation VR 4 weeks, they pay $650 to a medical service center. They need $300 for the whole operation for this patient, and then $350 goes to the company, the VR company. So I thank you for your attention. This is the team. I'm only speaking here, but these are the ones that are now taking care of all our patients. Thank you very much. Any questions? Do I have three minutes left? Maybe one question?
How do you sterilize the headsets between use?
Sorry?
How do you sterilize the headsets between use?
Do scale?
Sterilize?
Oh, we clean them and disinfect them, UV disinfection, yeah. Actually, we published a study on the quality of disinfection of VR glasses, not only bacteria, but also viruses. It's 99.9%, only, I think, 2 minutes, and then it's ready. Okay. Yeah, is that allowed, Sam? Yeah, you're now...
How many patients are you able to see with the first amount of VR headsets you bought year one? Because you're talking about scaling up. I'm trying to figure out, did you have to buy more VR headsets, or the number you bought year one was just enough for you to scale up?
Yeah, that's a good question, because we try to do as with the most limited amount of glasses. So it means that you really have to have a logistic process, which means that you foresee that the patient is going home at day 4, day 5, and then the glasses after sterilization goes immediately to the other. So to give you an idea, so we run this now with 25 glasses, but to be honest, we have 75 for our outpatient. So we are quite flexible. But that means that you also have to think about what type of app store you have on your glasses, and how do you be as flexible, because some of these apps are very expensive for license. So you like VR Hypno, which our pediatrics are using quite a lot. We only have that on 6 headsets, but that means that we have to puzzle sometimes. But that's not rocket science, because there are a lot of people that have to puzzle with equipment, and therefore there are people that are very experienced in logistics. I'm not. Is that an answer to your question? I think I must be strict as a moderator, so...